Hello, everyone, and welcome to today's GlomCon seminar series. I'm Dia Waguespack in Houston, and I'd like to welcome you all. Today, our talk is titled Glomerular Manifestations of Dent Disease, and we are very excited to welcome our two distinguished experts from the Mayo Clinic who are joining us today. First, I'd like to introduce Dr. John Lieske. Our second speaker is Dr. Alessia Buglioni.
Yep. Good morning, everybody. We're very happy to be here this morning, and I'll get my slides up here. So there. Awesome. All right. So hopefully is that showing?
Mm-hmm.
Perfect. All right. So I'm going to take us through a case, and then I'm going to turn it over to Alessia to go through the pathology. So disclosures, nothing related to this. We do have some clinical studies in one of our other rare diseases, primary hyperoxaluria. So our case is an 18-year-old gentleman. He had a creatinine that was elevated at 2.0 milligrams per deciliter. His 24-hour urinary protein excretion was also high at 4.5 grams. There was a question of some subclinical kidney stones on a renal ultrasound. His urine calcium excretion was quite high, 581 milligrams per 24 hours. As a reference, normally this should be around 200 milligrams per day or less. He was treated with hydrochlorothiazide to try to reduce that, which would be a standard thing we might do for hypercalciuria and kidney stones. He did have a kidney biopsy elsewhere that had shown a normal glomeruli and some interstitial fibrosis. They did not do electron microscopy. Minimal change was the presumptive diagnosis, so he was started on prednisone, 60 milligrams per day. His protein did seem to respond a little bit to 2.5 grams, but then was back up to 5.2 grams when his prednisone was tapered. He was changed over to cyclosporin, and prednisone dose was reduced, and there was a question, was this really focal segmental glomerular sclerosis? There was a family history of chronic kidney disease in a maternal grandfather. So when he was first seen here at Mayo Clinic by one of the other members of our division, he was now 21. His blood pressure was kind of low, 96/62 on the hydrochlorothiazide. He did not have any peripheral edema. His creatinine was slightly higher now, 2.2, but his serum albumin was normal, 4.8, and his cholesterol was not particularly high at 212. His serologies were all normal, including complements, ANA, hepatitis A and B. His urinalysis was pH 6.4, a few red cells, a few white cells, but not terribly remarkable. The 24-hour urine protein here was 2.3 grams, but his urinary albumin was sort of low at 193. So this was his kidney ultrasound, which really was most remarkable here for just some echogenicity. So it looked like it was some chronic scarring more than anything else on the kidney ultrasound. So he did have a kidney biopsy done here at Mayo Clinic, and the report was 4 out of 21 glomeruli globally sclerotic with no mesangial expansion or deposits. He had a question mark of glomerular enlargement, some patchy interstitial fibrosis, some sparse mononuclear interstitial infiltrate. There were some discrete interstitial crystals, which were non-polarizing. There was note of some protein resorption granules in tubular cells. The IF was negative. And his electron microscopy, the basement membranes appeared normal with normal foot process effacement. So this is one image from the H&E on his kidney biopsy, which showed this one globally sclerotic glom and the other one not so remarkable. And then this is the Yasu stain of his kidney biopsy showing the crystals here, which were more in the interstitium than anything else. There weren't any clearly obstructing tubules that were noted. So following this, he had genetic testing done for CLCN5. There was a strong suspicion of Dent disease based on all of this, which we'll go through later why that might be. And he did have a novel frame shifting mutation that was deemed pathogenic. So the diagnosis here was Dent disease 1. So with that, I'm going to stop sharing and
Okay.
let the actual pathologist tell us about focal sclerosis.
Thank you, John. So you should be able soon to see my screen. Am I sharing yet? Let's see.
We saw the desktop, but I think it's
Okay, you
coming
did.
now.
Okay.
Yeah, we just don't see the presentation. There it is.
Okay. Okay, good. All right. So I just wanted to give an idea what in general we look for in a kidney biopsy, and then we talk a little bit about Dent disease. But in general, when we approach a kidney biopsy, we look at the three major compartments: glomeruli, tubulointerstitium, and vessels. And so in the glomeruli, in general, when we talk about them, we think of focal or diffuse. And when we say that, we mean is what I'm going to see present in more than 50% of the glomeruli or in less than 50%. And so if it's in less than 50%, it's going to be a focal process. If it's in more than 50%, it's going to be a diffuse process. And then within the glom itself, if we think about it as a pie or a pizza, something segmental is going to be just a piece of that pie. Something global is going to interest the whole glom. And so in general, we look for all proliferative or segmental features. And so they could be focal, segmental, global proliferative features or diffuse, or focal or diffuse segmental global sclerosing features. And in those cases, we use acronyms. I, in general, don't like acronyms, but I think everybody is very used to hearing FSGS, focal segmental glomerulosclerosis, or FGGF, FS, focal global glomerulosclerosis. And so we mean it's something that it's involving less than 50% of the glomeruli, just part of the glomeruli or the whole glomerulus. Then in the interstitium, we look for interstitial fibrosis and tubular atrophy, inflammation, if there is any degree of acute tubular injury, if there are typical or atypical casts, if there is calcium deposition, we may see that, usually oxalate or more commonly phosphate. And then we look at the vessels. Is there intima sclerosis? Is there intima hyalinosis? The muscle hypertrophy because maybe it's responding to high blood pressure, and so on. So in Dent disease in particular, what has been described and reported in kidney biopsy is FSGS or FGGS. So again, something focal, usually involving less than 50% of the glomeruli that you have present in your biopsy. And it tends to be or segmental or global sclerosis. So all the capillary loops are obliterated and there is no blood going through to be filtrated. In the tubulointerstitial compartment, many things have been described: interstitial fibrosis and tubular atrophy, inflammation, acute tubular injury, and usually calcium.